afternoon, everyone, and welcome back. You are now in session 2.3, titled Research, Evidence, and Mechanisms for Action. I'm so pleased to have an expert panel with us here today who will discuss what we know, how we can learn more, and how to promote future research and implementation. Today's session will be moderated by Dr. Brea Perry, Professor of Sociology and Associate Vice Provost for Research at Indiana University. Dr. Perry, I will turn it over to you to take us through the rest of today's session.
Thank you so much. I am so pleased to be here and really excited to hear from this outstanding group of panelists that we have here with us today. So I will go ahead and introduce them all, and then they are going to provide about a 5-minute introduction to what they do, sort of who they are. And then we will start in with some directed questions. So our panelists today are Tom Hill. He is a senior policy advisor in the White House Office of National Drug Control Policy. We also have Dr. Beth McGinty, who is a professor of health policy and management at the Johns Hopkins Bloomberg School of Public Health. And we have Jessie Gaeta, who practices internal medicine and addiction medicine at Boston Healthcare for the Homeless Program, and is also an assistant professor of medicine at Boston University School of Medicine. So we will go ahead and kick it off with Tom, who is going to provide some introductory remarks.
Thank you so much. And yes, indeed, really pleased to be a part of this panel. We met last week, and I feel like I'm in really good company here. So good afternoon. My name is Tom Hill, and I'm a person with lived experience. So first, I'm a member of a family that has experienced generations of substance use, addiction, and mental illness. Second, my direct lived experience with using substances and addiction is as equally important as my lived experience as a person practicing almost 29 years, later this month, of abstinence-based recovery, which was my choice. I feel neither shame about my addiction nor particularly heroic about my recovery journey. It's all just become a part of my life, a part of who I am. As a queer man, my pronouns he, him, his in recovery, I have learned that when I treat all people with dignity and respect, I can expect to be treated the same. I'm currently serving in the Biden-Harris as a Biden-Harris political appointment as senior policy advisor at the White House Office of National Drug Control Policy. We call that ONDCP. The administration's first-year drug policy priorities have a strong focus on reducing the rising overdose death rates in our country. And we are committed to grounding all of our work in the latest science, research, and evidence. Aside from addressing the supply of drugs into our country, ONDCP's public health response addresses access to quality treatment, including medication with incarcerated populations, harm reduction services that include syringe service programs, fentanyl test strips, and naloxone, youth prevention, workforce issues that also include recovery-ready workplaces, recovery support services in general, and then an overall theme that we shared with the entire administration on racial equity. So we're now in the process of developing our 2022 National Drug Control Strategy, and that will be released in February of next year. Operations are underway that's well started and being initiated in terms of various drafts. So stay tuned. I think it's going to be really, really exciting. That's all from me. Thank you.
Thank you. That's super interesting, and I can't wait to hear more. Next up is Beth.
Hi, everyone. I'm pleased and honored to be part of this panel this afternoon. I'm a researcher by training. One of the several hats I wear is director of the Center for Mental Health and Addiction Policy at the Johns Hopkins Bloomberg School of Public Health. And within the center, I'm one of the leaders of a group called Stigma Lab. And Stigma Lab is a group of researchers focused on rigorously studying stigma reduction strategies, and specifically communication strategies, the types of messages to reduce stigma that we disseminate through large-scale stigma reduction campaigns, billboards, television ads. You see them in healthcare settings where there are messaging campaigns disseminated on screensavers and electronic bulletin boards, et cetera. We try to rigorously study and evaluate those messages to make sure that they are in fact stigma reducing and that they don't have unintended consequences. So we use a variety of research methods to study stigma reduction communication strategies with a strong focus on strategies to reduce addiction, stigma specifically, and stigma toward drug use more broadly. And those methods include news media content analyses, surveys to test the persuasiveness of different types of messages, as well as randomized experiments to formally test whether different types of communication strategies have their intended effect of reducing stigma. A key theme of my remarks today that I'll just tee up briefly here in the introduction is the absolutely critical importance of rigorously evaluating these types of stigma reduction strategies. Too often we design messages sort of based on our gut feeling about what might work, and while well-intended, there are some real cautionary tales about that approach. Where we see messages that are not effective being disseminated broadly through really costly communication campaigns. One fairly well-known cautionary tale from the world of mental health stigma reduction is the Disease Like Any Other campaign, which was a national large-scale campaign in the 1990s with the tagline of mental illness is a disease like any other. I could imagine putting myself in the room of folks who came up with that message and saying, yeah, that seems like that might be stigma reducing, it might be normalizing. After the fact, after a very large scale costly campaign, research by Bernice Pescasolido and colleagues showed that not only did that campaign not reduce stigma by some measures, it actually had the unintended consequence of increasing stigma, perhaps due to the fact that the disease framing increased perceptions of the permanence of mental illness. And so that's the kind of cautionary tale that our group tries to help fend off in the future by developing and testing rigorously messages before they get disseminated in the field.
Great, thank you so much, Beth. That's fascinating. Okay, next we'll hear from Jesse.
Good afternoon, everyone. I'm really excited to participate in this conference. I've been learning a lot all afternoon. My name is Jessie Gaida. I'm an internist and addiction medicine specialist in Boston at Boston Healthcare for the Homeless program. And we are a community health center with about 40 different clinics around the greater Boston area. And just to give you a sense of where I'm coming from and where our practice exists, we have had as the #1 cause of death for the last 15 years in our practice, drug overdose death. And in fact, in the fentanyl era here in Boston, which really started in earnest in 2014, since then, overdose death accounts for 1 in 3 deaths of the patients that I see at an average age of 43. In the building where I'm sitting right now, at our main site on the corner of Mass Ave and Albany Street, this is really the epicenter of the overdose epidemic in Massachusetts. We respond to about 5 overdoses every single week in the building that I'm sitting in right now. Just by way of introduction, I wanted to share with you 2 quick stories about stigma from my practice that are just so memorable to me. The first story is one that really seemed to play on repeat for a number of months, and that ultimately led to the creation of a harm reduction program within our community health center. I can see it really clearly in my mind because it's happened so many times. I'm on the floor in our public bathroom in our main building here in clinic, I'm hunched over a young woman who we've just revived from overdose using naloxone and rescue breaths. And as she begins to wake up, just underneath me, feeling the immediate withdrawal from opioids, she's both disoriented and afraid. She's half dressed, she's shaking like a leaf, she's started to sweat, and she's completely vulnerable in that moment. And I feel really frustrated. Our team feels worried because she's a stranger to us. She isn't well engaged in our clinic, because even our services, which are far from mainstream, are fairly structured. And it's hard to imagine this woman sitting in a waiting room before she's being seen. So there are elements of the way that we operate that simply make her reluctant to engage with us. But the single greatest reason for reluctance to engage in healthcare and social services is stigma within our systems. So as we've had called 911, she and the paramedics have arrived, she just adamantly refuses to go with paramedics to the hospital. She's completely reasonable because of fears of being stigmatized there. And we're afraid to see her walk out the front door. We don't know if we'll ever see her again. And all I can feel in that moment is like desperation to let her know somehow that we can be here for her no matter what is happening. And I want to know her better. So just the reluctance to go into the hospital after an overdose, I think, is one great example of stigma. And we hear heartbreaking stories of trauma and loss and stigma at the intersection of homelessness and addiction that cause so many people to avoid many healthcare settings and actually social service settings as well, reasonably and relentlessly. And so with some understanding of how much stigma is playing into this, we started to really shift our programming here in 2015, and we opened a harm reduction program called SPOT, the Supportive Place for Observation and Treatment. And this is a program we just opened up out of desperation to save lives and really to deepen our relationships with people who are actively using drugs. This is a non-judgmental drop-in space focused on reducing the harms of drug use, where we've provided overdose monitoring and harm reduction services to thousands of people. From the beginning, we really tried to design this program by trying to listen as best we could to the needs and concerns of people actively using drugs. We want to make it clear in this program that no matter what you're doing, we want to care for you. You have worth, and we love you. Where someone might see struggle, we really should be seeing resilience and great strength. In this program, we've sort of shifted the paradigm that we hear so often and said, you really don't need to stop using in order for us to start offering help. And this brings me to the second story. So often unwilling to go to any other provider in our healthcare system, one woman who we had never seen before we opened this program began coming in during periods of really severe, dramatic sedation from substance use. And one morning, after several hours of sort of waking up, she just was completely surprised to be in a healthcare setting and feel this loved. I remember her literally waking up and saying, like, what is this place? She was like in total shock. Who are you? I haven't slept on a pillow in years. Why do you care about me? And this was just a hint of how she had internalized what I would later come to understand is just decades of deep and intersectional stigma with addiction at the center of that. And on a different day, when we narrowly convinced her to go to a local emergency department for care of a serious wound infection, she later described the experience in the emergency room to us. And I couldn't believe that her wound was debrided without local anesthesia. And I've actually heard that story many times since. But also she recounted the following that just sits with me. A nurse actually jabbed a needle in her arm aggressively and without consent, surprising her. And when she flinched and screamed, the nurse said, "It's a hepatitis B vaccine. What's the problem? You do this to yourself all the time." I just thought I would start with those two stories.
Wow, thank you so much for sharing those really important stories. I think it really illustrates the stigma that people with addictions face in the healthcare system. And I'm so glad that you're doing the work that you're doing to care for them and show them that they're valued. So as you can see, we have an outstanding group of panelists here with sort of a range of experiences and expertise. And since this panel is about research and evidence, I'd like to start by asking Beth and then others, what do we currently know about the stigma of addiction from the scientific literature?
Happy to start us off here. This is a tough question to get the universe of research in a short, concise answer. So I will take a stab, but admittedly not be comprehensive. And I look forward to my co-panelists jumping in with points that I have missed. So I'll make 3 points here about what we know in a foundational way about stigma from the scientific literature. So, first, we know that stigmatizing attitudes surrounding drug use and addiction are pervasive and persistent among both the general public and among professional groups that serve people who use drugs and people who experience addiction, including but not limited to healthcare providers, as you heard in some of Jesse's really compelling stories just a moment ago. I won't bore you with a laundry list of statistics here, but one illustrative statistic that I'll use to sort of frame up this issue is that a recent national survey that our team conducted with a representative sample of primary care physicians in the US who are at the front lines of treating people who use drugs, although they're not addiction specialists. We found that 75%, 3/4 of primary care physicians in the US reported very high levels of stigma as measured by social distancing attitudes, which is a standard way of measuring stigma. So 75% of primary care physicians said that they were unwilling to have a person with opioid use disorder marry into their family. 2/3 viewed people with opioid use disorder as dangerous. And those statistics are as high or even a little bit higher than the same measures of stigma as determined by social distancing attitudes that we see in the general population. So I think many of us often have a prior that, healthcare professionals might have less stigmatizing attitudes than the general public, and evidence suggests that on a national scale, that is not the case, and that we have a lot of work to do there. The second point that I will note is that it's well established in the literature that a really key driver of stigma toward people experiencing addiction is the belief that addiction is a personal choice, reflecting a lack of willpower and a moral failing. So when we think about overcoming stigma, that belief is a key one that we need to surmount. And then third, circling back a bit to my particular area of expertise around communication strategies to reduce stigma, the evidence has identified some guiding principles for communication strategies to reduce stigma. I say guiding principles rather than sort of definitive effective strategies, because this is a pretty limited area of research to date. There's a lot of work to be done. But the principles that we have identified are, one, that language is incredibly important. Small language changes can have big effects on stigmatizing attitudes. In particular, there's rigorous evidence from randomized experimental studies showing that using person-first language, so person with a substance use disorder, is significantly less stigmatizing than using terms like addict. That conflate the person with the condition. There's also evidence from experimental studies that the term abuse is problematic, I raise this one because it is so widespread and institutionalized. I get much of my research funding from the National Institute on Drug Abuse. This is very problematic, and not only because this is a term that has been shown to be stigmatizing in recent studies, but also because it no longer has any valid clinical meaning. Since the most recent release of the Diagnostic and Statistical Manual, which is the manual we use to diagnose mental health and substance use conditions, there is no such clinical condition as substance abuse or drug abuse. There used to be, which is why this term has been so institutionalized, but now the clinically meaningful term is substance use disorder. So really working to scrub that term abuse from our vocabulary and from our institutions is a priority in terms of stigma reduction. The next guiding principles that I will emphasize briefly, 3 more guiding principles around communication. One is that evidence suggests that messages emphasizing solutions can be destigmatizing. I think this is intuitive when I say it out loud, but often when we talk about public health problems in general, including but not limited to substance use, we're very focused on talking about the problem and less so on framing it as a solvable issue. And so talking about solutions, and there's a broad range of evidence-based solutions, prevention, harm reduction, treatment, in messaging can actually be stigma reducing. Next, there's evidence that use of sympathetic narratives that meld compelling personal stories with cues about the societal and biologic factors that influence addiction can reduce stigma. This is, I think, a very important point in that the communication research shows that there are some downsides to personal stories. They are emotionally engaging, but if they don't pull in some of those cues about societal forces contributing to the problem, they can actually backfire and lead audiences to blame the individual telling the story for their own problem. And then finally, and this is where I will stop with my whirlwind overview of the evidence, there is good research showing that it's important to really emphasize those societal rather than individual causes of substance use and addiction. So I'll stop there. Thanks.
Excellent. Thank you. That was very thorough. So I was hoping that Tom could follow up because one of the things that Beth mentioned, but didn't talk a lot about, is this issue of, what causes people to become addicted to drugs, and this issue of a moral failing. So I'm hoping that you could tell us a little bit more, given your experiences and the work that you do. What is it that drives stigma? What are sort of the beliefs or attitudes that underlie the public's inclination to exclude or avoid people with addiction?
Absolutely. And thank you so much, Beth, for that layout. That was really, really nice. And, I just want to add that, I've been doing recovery community organizing for over 20 years. And we started talking about language and the word abuse over 20 years ago. So it's great to see it used less, and yet it's like people still cling to that word, and it's institutionalized, so I get it. But there's also concepts like calling somebody clean or dirty, calling people non-compliant, as if they have no part in their own healthcare or well-being. And even just the word, not only the word abuse, but the word abuser. And for folks who have suffered abuse, like myself, a high ACEs score, it has a particular sting. So, it's like I'm glad this research, we need more research on that, but it's like you can't change your attitudes unless the language follows it or the language leads it. So I just wanted to say that. The solution stuff, we've been talking about strength-based, that people have the wherewithal to make their own decisions. People with addiction have the wherewithal to make their own decisions. And that's really a strength-based, not a deficit-based approach. And it is solution-based. We're going to talk about the stories later, I hope, but I do want to talk about the causation stuff because I think, there's been so much research done on trauma and how that affects addiction. And for me, it was really informative to start to piece parts of my childhood and life together through a trauma lens that started to answer questions as to why I experienced what I experienced, right? So I think, the science is catching up. We still have a lot of work to do, but I also just want to flag that we are living in a society right now where there is yet another wave of anti-science backlash that's happening in communities across the country. We've seen it with COVID, and we're seeing it with addiction again. And so, we really established a good base of a concept of addiction as a chronic brain disease. And that's a science base that's being refuted back to that idea of moral failing and character weakness. So it's disheartening to see that, but I think we really need to double down in terms of presenting the science, no matter what, that belies the belief that, I can't tell you how many times I've presented as a person with lived experience in recovery, and certain people have said, I didn't put a needle in your arm, you chose to do that yourself. And, that's a showstopper until you come up with the idea that, well, you know what, there's a lot of science behind why my brain became the way it did, and the way that drugs and alcohol countered that brain and then often affected that brain as well. So I think we have a big pull in our society to pull it back to science. And I think that it's, there are forces out there that just do not believe what the experts say. And we need to just say it louder and say it clearer. So I hope I answered your question, Brea.
Yes, that was perfect. Yeah, and I totally agree. It's so hard to counteract the sort of anti-science attitudes, particularly when people just sort of fall back on stereotypes, particularly in cases where there's a lot of uncertainty around a condition, or, we just tend to fall back on our base instincts, unfortunately. So I would like to talk a little bit about translation of basic scientific research. And someone in the chat actually asked about what sort of interventions work to reduce stigma. Beth knows very well, as do I, that it's very challenging to translate this research into policies or interventions that can actually move the needle on stigma or help individuals with addiction cope with stigma. So I would like to have Jessie talk a little bit, given her experience working with and on behalf of people with addiction. Are there sort of conditions within healthcare settings or strategies that you found that help to reduce stigma, even anecdotally? So what kinds of interventions have been successful in the work that you do, if any?
This is a really good question, and I just want to emphasize that I'm talking anecdotally, and that I don't have a great science-backed answer to this. I'll say, really thinking about healthcare and also social service settings, which is kind of where I sit. I found that, first of all, what we're really talking about is establishing a new culture often. And that's a really tall order among healthcare workers, social service workers, and it takes time. Some of the things I thought to mention that I think have been successful shifting culture in some of the places where I work have been, for example, hiring people with lived experience to do the work and embedding them in teams where there can be sort of direct confrontation about some of the unintended but still consequences of the ways that stigma plays out in these settings. I think in terms of establishing culture, it's really helpful to have people who are in leadership positions set a clear path and a clear vision for what the work entails, how we're approaching addiction in any setting. It's really helpful to have a clear vision set and and then to work to build buy-in among more and more people in a program or industry. And how do you do that? How do you work to build buy-in that that addiction is a chronic brain disease, for example, or that it's not a moral failing? I think there are lots of ways to do that. I think different things speak to different people, and I don't know, Beth and Brea, if this kind of bears out in the research, but I think you talked some, Beth, about the power of personal narrative, and I think for some people, especially in healthcare, perhaps science. There is some weight given to science, and if we can go back to the primary, basic science of substance use disorders, and present that, or we can show outcomes from various, what we would think of now as evidence-based treatments, et cetera. I think science does help in these kinds of settings. For some people, that really does help drive the needle a little. I think also setting up the chance for people to process and talk about what this means to them in small group settings, that can be hard to do and it can backfire also. But I think people need a chance to talk about the shift in culture, what it means for them, to talk about their feelings about addiction, and to do that in a way that's going to be sort of safe, so sort of small group facilitated discussion. Processing, I think, helps. And then finally, I think at some point we have to not settle for pathologic culture. We have to set a hard line, and we have to stick to it. And that's easier said than done. But those are some kind of anecdotes that I thought of.
Those are so valuable. And some of the things you said made me think a little bit about some of our research, which looks at the effect of social contact on stigma. And we find that one of the best ways to reduce stigma is to foster sort of meaningful, positive social contact between a person in a stigmatized group and someone in the general population. And so, having these contacts, as you mentioned, is so important. And this also leads me really naturally into the next question, which is about bringing people with lived experience into stigma reduction research, right? So how can we do this? Why should we do this? What unique strengths do these individuals bring to the table? And I would love to, given your experiences, hear from all of you on this question. Beth, do you want to go ahead and, Tom, you want to start? Go ahead.
I'll go first. And I just want to just make a comment to what Jesse said. We do have research we have corporate research in customer satisfaction. And there's been a lot of lessons learned in terms of return policies, customers coming back, treating people well, that it's a very different culture than it was 20 or 30 years ago. Think about going to a return line at the department store after Christmas and having to deal with all of that. So the bottom line there is, if you treat people right, you treat people well, they'll feel comfortable and they'll come back if they feel respected and honored. So I just wanted to say that. The thing about lived experience, and I think we have to be careful about this, because not one size does not fit all. And I think it's really important that we do sort of expect to have people with lived experience at the table now. We fought hard for that. I think our stories are really important, but I also, I go back to what Beth said earlier about the principles about the stories and the lessons learned there. And I think another lesson learned is how do we build a framework for those stories, that we don't create a them and us, and that we don't separate the innocent victims from the bad people doing bad things. And I think we have a history of that, of sort of cherry picking the stories that we think will win people over, rather than having authentic lived experience stories and narratives that are often crafted by the people themselves in a way that is to their own ends. So I just wanted to say that, because I think we're always in danger of doing that. And it seems like an easy early win, but I think it backfires in the long run. I'll turn it over to somebody else.
Yeah, I can go next. So
Did I freeze?
I agree with Tom's points. I think that my view here is that it's really critical to include people with lived experience in this line of research, and all of the research I do around mental health and addiction policy. I think sort of part of being a good scientist is assuming that you don't really understand an issue if you haven't lived it. And so you need to sort of, as a starting point, engage with people who have lived experience. I think in terms of stigma reduction, it's just really illuminating to understand all the ways that stigma manifests, which, I think Jesse perhaps sees as a healthcare provider, but someone like me, who's an academic researcher, doesn't see it on a day-to-day basis. And so having people embedded in my teams who have lived it sort of keeps the whole motivation for this work very front and central, and also helps sort of craft, as Tom was alluding to, authentic messages that don't inadvertently exclude or other the people that we're trying to help by reducing stigma. Just totally practically, I think a lot about how to do this well in a research environment. I don't think I've struck on the perfect way to do it yet, so I'd love to hear others' ideas. But I think there's a variety of ways to do it. As a mental health and addiction researcher, I try to hire folks on my team who have lived experience and who are, then sort of full-time members of the research team, contributing equally in the same way that I am. In cases where that's not feasible, we often use mechanisms like advisory boards. I think doing that well is challenging in that those types of boards often include a lot of people, including but not limited to those with lived experience, and you need to really make sure that everybody has an equal voice and equal power. I won't go into tons of details about how one does that, but there are some strategies out there, and I think it requires a lot of intention to do well. I'll stop there.
Thank you. Jesse, did you want to add anything?
No, I don't think I have anything to add to that.
Okay, great. So that was a really interesting discussion. One of the things that I want to make sure that we have time to talk about is the issue of intersectionality. And for those in the audience who may not be familiar with this term, it refers to sort of the interconnected nature of social categories like race and social class and gender, and how these forms of social inequality might influence or interact with the stigma of addiction. And of course, it didn't escape any of us when we were planning this panel that we are all white. And that, some people who have addictions are not white. So I think discussing this issue of intersectionality and how things like race and social class might play into the stigma of addiction is really important. So I wanted to make sure we got to that. So Tom, did you want to start us off with this? I know you had a lot of really interesting thoughts about this during our initial discussion.
I will, thank you. And I think, I'm always on a delay. I just wanted to say one more thing about lived experience. I'm sorry. It's the other thing about inviting people with lived experience to the table is that you need to take the time to process and prepare people. Because they may not speak the same. It's a culture shift again. They may not speak the same language. They don't know the vocabulary. It's a lot of patience, but it's sort of coaching and mentoring to sort of make them feel comfortable in any given situation they're in. And I would be remiss if I didn't talk about participatory research also as a community-based way to bring in people with community and lived experience. Mm-hmm. The thing about intersectionality, so I told you I've been doing recovery community organizing for a long time. And in the late 90s, I had a group called Speak Out, LGBT Voices for Recovery. It was out of the community center in New York City. And we had a group that was very, very diverse. And the kinds of discussions we had about stigma, about language, about all these things. We talked about harm reduction versus abstinence-based recovery. We talked about all these things, but we really talked about what we brought to the table in terms of various cultures of queer people, Puerto Rican experience, Black experience, lots of trans experience, like all these different sort of identities that people had brought in, and lots of layers of trauma, and lots of layers of hurt, and lots of layers of stigma. And we sort of tried to figure out a way to unpack that as a group, to talk about advocacy and peer services in a way that and it was important for me because I didn't want to design recovery services that were built around a white experience that looked good to me, but didn't include people the way I thought it might include them because they didn't see themselves reflected in the programming. So we built all the programming from scratch and had everybody build it in a way that made sense to them and that made sense to the whole. So I learned a lot of really important lessons there about people who I never really saw as being left out of the picture that had always felt left out of the picture, even the recovery picture. They saw recovery as a white thing. So it's like when you unpack all of that and you see tons of intersectionality, tons of people that were excluded no matter what community they were a part of, and they were part of many communities. There was always a piece of them that they couldn't bring in. And so it affected their sense of wholeness. They were very fractured. So I don't know what point I'm trying to make with this, only that there's an intentionality that we need to bring in terms of when we talk about stigma that is going to affect people in various different ways. And they're bringing stigma from a lot of different parts of their lives, not just their substance use or their addiction or their homelessness or any of those things.
Yeah, that is so important. I mean, not to mention that, people in the general public view people of different races or sexual orientations or genders with addiction differently. Right. So we know that those things can magnify the experiences of stigma. Right. So yeah, that was great. Thank you. Jesse or Beth, did you want to weigh in on this?
I mean, as I was thinking about intersectionality and stigma, first I was just remembering that the person that came up with this term intersectionality in the late 80s, I believe, was a Black woman, a law professor named Kimberly Crenshaw, and she was really creating this term, I think, to describe the way that Black women felt in a largely white women's feminist movement that, has been now, I think, used in lots of other ways, but just to recognize that. But so as I think about the intersectionality as it relates to the stigma of addiction, I think that the place where my head goes right to is really thinking about the intersection of stigma around race, identity, and addiction, and just sort of recognizing the profound ways that the racist war on drugs, which has been our society's primary approach to addiction in the last 4 decades, has shaped our mindsets about addiction and how much it has really informed our opinions about people with addiction. And I'm thinking even about the fact that we've moved so far and we're still trying to move the needle toward, public health approaches. Of course, that's happening at a point in time where an opiate epidemic, has affected, or at least has been talked about as more of a white condition. So just even the fact that like we're sort of thinking about addiction from the point of view of stigma in recent years so much has some overtones that are so racialized. And so that's really where my head goes most when I'm thinking about stigma and intersectionality.
And I'd just like to, that's where stigma bleeds into discrimination, because they're very closely linked. But then we have policies that are discriminatory and really damaging to entire communities of people over many, many decades. And so it's and targeted at that experience. So I totally agree with you.
Beth, did you want to weigh in on this one?
I think the other panelists covered it.
All right, sounds good. So I wanted to, this went so fast because it's been so interesting, and you all are so knowledgeable, that we're sort of getting close to the end of our time together. So I wanted to ask you all, I want to leave the audience, I guess, with something that's gonna help them remember sort of why we're all doing this work and why this is so important, right? So I'm hoping that you can weigh in on the costs of ignoring the problem of addiction stigma. So, how is stigma affecting the lives of the people that you work with, the people that we're studying? And what happens if we just pretend that this doesn't exist, right? So I'll let you guys go ahead. Jesse, do you want to start with this one?
Sure. It's, I'm thinking about like even the stories that I told at the beginning of this session. I think if we ignore stigma, if we don't, really take this on, take ownership of this in our society and work to change it, then the two cases of the women that I talked about, they're not going to come into healthcare settings. They're going to die prematurely of things that are treatable. And, more broadly, I guess I would say that we'll continue to see this profound effect on people's self-worth, like the how much people will continue to internalize the stigma that they're feeling from society around them. I think it just has so many detrimental effects, and we've heard from so many speakers actually throughout this whole program about the effects of kind of internalized stigma and oppression on people with addiction. It's absolutely deadly. I'm not sure what else to say about it. It's deadly.
Yeah, I think that's really well put. Anyone else want to weigh in on that?
So it's not, we have evidence right now that it's deadly because we have an overdose death rate that is just alarming and going up. And the systems that we have that are, I think, largely influenced by decades of stigma are not working very well. So people show up for help. We often don't treat them very well. We don't trust them to make their own decisions and choices. And bottom line is we don't expect them to win. And we're expecting them to fit into systems that we know don't work, and then we blame them when they fail, which just exacerbates stigma. And so, we have research on social determinants of health. We have research on recovery capital. I came in with relatively large recovery capital, but a lot of people don't. A lot of people don't have the resources to put together to even access healthcare, much less addiction treatment. We haven't even talked about the stigma of medication. We haven't talked about the stigma of methadone for 50 years. And that's embedded in our system. So we have answers that are stigmatized, and then we have to fight against that. But the system we designed is really built for acute care. It's not built for a chronic care model. It's not addressed for long-term care, and people cycle through it many times, and we say, well, you just relapse again and again and again, and we stigmatize them for that. Even the word relapse is stigmatizing because of the sort of shame we put on it. We don't do that for other chronic conditions. We don't do that if somebody has a piece of cake, somebody who has diabetes has a piece of cake. We don't shame them and say, well, you failed. We get them back on course again. So this, what Jesse's talking about with the women with those stories is, folks that have been really abused by the system and are gun shy to come through the door because of the way they've been treated. And so how do we build systems that engage them? We know that harm reduction has engagement tools that keep people coming back because they don't feel judged, they don't feel stigmatized, they're offered a cup of coffee when they come in, or a warm blanket, whatever, and people are treated really well and they come back. And that level of engagement, we don't have anywhere else. We penalize people for not showing up for their appointment without asking them what kept them from making the appointment. There's just little tiny things about customer service, about treating people with dignity and respect that I think that is a culture change. And I think that's, the stigma reduction starts here. It starts right here. And then it fans out. And so I need to take responsibility for ways that I promote stigma and don't do it anymore. And everybody else, both in our healthcare system and in our society, needs to sort of figure that out. So I just realized that I stepped right up on my soapbox, so I'm going to just sort of gently step down. But I think, some of these answers are in front of us, and they're very, very simple. And they have to do with human compassion. And you can't have human compassion if you're blaming somebody for their medical condition. And we don't do that with too many other medical conditions. All right, I've said enough.
I just got chills. So I think that was really, really well put. And also reminds me that this panel could be like 4 hours, and I would enjoy sitting here talking to all of you and learning from all of you. We have just 1 or 2 minutes if you guys have a last thing that you want to say, something you really wanted to express that you didn't have a chance to get out yet. So, please, if there's any last minute stuff you got to say, get off your chest.
I have one thought that I've been sort of increasingly focused on, which is that, I think that as we think about stigma reduction, and particularly stigma reduction among professionals who are working with people who use drugs, I think that where the field needs to go is to figure out ways to sort of integrate stigma reduction alongside other evidence-based practices. I work with a lot of healthcare systems on stigma reduction, and even a very highly evidence-based communication campaign. It seems to me that it will be unlikely to reduce stigma if frontline providers in that system don't have resources to effectively treat or refer to harm reduction, the people who they serve. They have incredibly, frustrating experiences on a day-to-day basis, and are sort of unable to help the people who they want to serve, and that reinforces stigma over and over and over again. And I think that the field so far has really not thought about stigma reduction in that way. It's done in this standalone, let's do a campaign, or a smaller scale, deeper sort of social contact based intervention like Brea was talking about, which is quite effective but hard to scale in a broad way. And I just think that the sort of paradigm that we need to shift towards is that stigma reduction is going to make implementation of evidence-based practices around addiction more effective, and those evidence-based practices are also going to make stigma reduction more effective.
Yeah, for sure. Unfortunately, I have to turn it over to Aisha now to end the session. Thank you all so much. I have learned a lot. It's really been a pleasure meeting and talking with all of you.
Absolutely. Thank you to you as well, Dr. Perry, for moderating, and to all of our panelists for your remarks. I have to agree with Dr. Perry. I think this session alone probably could have spanned the entire summit. It was an incredibly fascinating discussion. I think each of you brought a really important perspective to the topic. We will be taking a 30-minute break now. So the next part of our program will be the innovation session, and that will begin at 3:40 p.m. Eastern time. So thank you so much, and we will reconvene soon. Thanks, everyone.
Thank you, guys.
Thank you.